first, those people that are here, you don't have to come back and do this. So that's a good thing. All right, so anyway, we're going to have 2 injections that we do. One is to prepare a heparin injection. The things that I would like people to do is, first of all, you have to determine the gauge. You have to determine the slant of the needle and the location, because there is a location that you want to use for this. Okay, so we talked a little bit about this before. So do you remember what I said? Where do you give a heparin injection? In the lower abdomen, what I call the smiley, because it's below the umbilicus. That's where you give it. Now, you can give Lovenox higher. It can actually be given above the umbilicus. There's a difference, though, between how heparin is given and how Lovenox is given. And we give a lot of it up on MedTele. A lot is given, because those individuals have a lot of thromboembolus, and we have to be aware of that. So, usually the dose is around 5,000. So I'm having you do something that I know you're going to use, okay? It's not something that's just fluff. All right, so when we give an injection, it comes in a little bitty ampule vial. The vials that I have, and Danny, I know you've given these before, so you know what I'm talking about with it. There's only enough in that syringe to fill the syringe. There is a dead space in the syringe, and I'm not trying to be rude in saying that. In the syringe, it actually has a little bit of extra space up where the needle is located. And I have an example of the needle, so you can kind of see. This needle has a dead space in it because there's an extension on the end of it. What that does is you lose about 0.2 milliliters of the solution. That specific vial, the heparin vial, only has 1.2 milliliters in it. You lose any, and then there's a problem. Now, I do not have any spike needles here, but they're plastic spikes, and I like to use those when we're in the clinical unit because I think you find that it draws up a little bit better. And I can get all of it in instead of part of it. So that's one thing that we want to make sure you know about. But be careful when you remove the syringe or remove the needle from the syringe, from the actual ampule, because what happens is it can splurt all over the place, and then you're getting another vial. Okay, so that's one thing we want to talk about. So location is below the umbilicus. Okay, you're going to use a slant on the needle, and what kind of a slant would you have on that needle? Usually it's 45, but if I have somebody with a pannus, you can do a 90. So 45 to 90, depending upon your patient. A lot of that is determined by your judgment based on the patient. Okay? Danny, what's your experience with that? Have you had anything other than that, as far as experience with needles and things like that in the clinical setting that you've had with patients and giving heparin?
Well, I guess the joint needle works better, absorbs better.
Okay.
And what I always question myself, right, is a 500 pound guy gets 500 unit of heparin every 8 hours, and there's other people who, they're not,
They're not
weights,
that big.
yeah, it's not done by weight or consideration, it's just a prophylactic. But, I mean, I don't know how is that going that, two different people get the same amount. So
That's a good point, because if I had somebody that was real small and I'm giving 5,000 units of heparin, what am I gonna have to look for with these patients?
Bleeding, especially if they've got a port and you're heparinizing that port all the time.
Exactly. And they don't always heparinize the ports. They may be, and they may not be, depending upon what's going on. Usually we would go ahead and do like a heparinizing of the ports. But if I had somebody that had bleeding, I'm not so sure doc would order that. So we have to be aware of the differences, okay? So you're gonna hear me talking about the PICC lines in a little bit and what we would do possibly different based on what's going on. I have a lot of questions when we have PICC lines. Okay, am I supposed to heparinize? Am I not supposed to heparinize? Am I supposed to use what kind of, am I supposed to have the stat lock, change the stat lock, What am I supposed to do in relation to these situations? So I'm questioning things. And then when I'm drawing blood, okay, how much should I draw? How many tubes do I have to have? Because I don't always know that and what kind of tubes I need for lab. I have to question things because that's not something I keep in my gray matter, and it changes with patients. It's matter, the mark of a truly learned person isn't how much you can whip off the top of your head, but are you willing to look, and do you know where to look? That's the thing. And then do you know when to ask and when not to ask? Those are two things to keep in mind. Okay, so you're gonna be doing this. You're gonna be drawing up. I'm gonna take you into the lab, or into the inner core, and you're gonna be drawing up your injections. The next thing that you will be doing is insulin injection. Insulin injection, I would like you to draw up this. Now, we talked about this as far as what you need to do differently. Sorry about that. And what we need to do differently about this. We have 16 units and a 20 units. Now tell me, which one would you put air into first? The cloudy. Which one do you draw up first? Very good. Now, we really don't do a lot of this, but I can tell you, this is a board question. They like to ask this because there could be a time when you actually have to do that. Okay, so where are the injection spots that we have for insulin?
Back of the arms, back belly, they can do the outer thighs,
And buttocks.
butts, yeah.
Okay, as far as absorption, which one is the quickest?
Is it the belly?
Belly is quickest.
The back, yeah, the back of the arm is thinner, it seems like,
But if I had a patient and their blood sugar was high,
do the belly.
I'd probably do the belly. If I wanted it to work and I wanted to work quickly, I would probably go abdomen. If it's something where they say, oh, I'll just put it in my arm, make sure that you're pulling up and lifting, and it's back here. This is where you want to give it, in this area, okay? And then thigh and buttocks. Most patients they'll do the thigh. I don't know a lot of them that like to do the abdomen.
That's all they do in the long term.
Yeah, we do a lot of
I've never
them. You
done
know
it
why
there.
now?
It's always the
It's the fastest absorption, is the abdomen. And I always thought that was kind of odd too, with all that, most people have a little belly fat. And it does make a little bit of a difference, I mean, as far as the absorption. However, abdomen, arm, thigh, buttocks, that's the absorption. Okay, so, and I think that kind of changes with the amount of abdominal fatty tissue you have. It has to. Okay, so you're supposed to give me the gauge size. You're supposed to give me the slant of the needle. What would be your slant of your needle? You could go, if it was a heavy set person, you could go a 90.
But it's about the same as heparin, 30 to.
Or 45, yeah. You could go a 45 to a 90, depending upon your patient. Okay, and then the location, we've already talked about abdomen, arms, thigh, buttocks. I'm gonna let you choose where you give it, but those are the things you're going to be doing for this. Do you have questions for me? Okay, so that completes this portion. So we can